Bismillahirrahmanirrahim. Acute cervicitis. This is normal cervix, and here we have a cervix which is inflamed, like in the cases of cervicitis. It is red inflamed primal cervix with a purulent discharge. So the presentation is post-coital bleeding. We're talking about cervicitis. Thick malodorous mucopurulent discharge. Signs are primal cervix, bleeds easily on contact. Diagnosis is done with NAAT. Treatment should be started empirically before infection ascends. That is erythromycin with ceftriaxone. Differentials are bacterial vaginosis, thin grey discharge instead of thick and purulent, and there will be fishy odor. For acute cervicitis, the etiology is infectious, in chlamydia trachomatis, and Neisseria gonorrhea. Non-infectious etiologies are foreign object latex and douching. Clinical presentation: asymptomatic, mucopurulent discharge, postcoital intermenstrual bleeding, and friable cervix. Evaluation: nucleic acid amplification testing and wet mount microscopy. Management is with empiric testing, that is erythromycin plus ceftriaxone. Depot medroxyprogesterone acetate DMPA injections. Why do we use them? For form of contraception administered every 3 months, inhibits the release of GnRH from hypothalamus. That is depot medroxyprogesterone acetate DMPA injections, and they are a form of contraceptive. Side effects are menstrual irregularities during first 6 months, amenorrhea after 1 year of use, weight gain, fatigue, nausea, and breast tenderness. So it is what it looks like. How do we do the amniocentesis? We use an ultrasound probe to look for the position of placenta and the fetus, and also to see the provision of needle. This is uterus, fetus, and amniotic fluid. Amniotic fluid index (AFI). The amniotic fluid index causes of, if it is less than 5 centimeter, then it is oligohydramnios. If it is more than 24 centimeter, it is polyhydramnios. Now, what are the causes of oligohydramnios? It can be because of preeclampsia, abruptio placenta, uteroplacental insufficiency, renal anomalies and NSAIDs. Complications can be meconium aspiration, preterm delivery, and umbilical cord compression. The polyhydramnios causes are esophageal or duodenal atresia, anencephaly, that is center for swallowing is lost, multiple gestation, congenital infections, and diabetes mellitus, which is hyperosmolality. Complications include fetal malposition, too much fluid and shift, umbilical cord prolapse, preterm labor, and premature rupture of membranes. Polyhydramnios. It is defined as amniotic fluid index of more than 24 centimeter or a deepest vertical pocket of more than 8 centimeter. So 2 to 8 is normal. For the vertical pocket, right? Deepest vertical pocket of 2 to 8 centimeters is normal. And for the amniotic fluid index, it must be between 5 to 24. Okay, if it is more than 24, it is polyhydramnios. Management is based on severity, maternal symptoms, and gestational age. Severe or symptomatic polyhydramnios at preterm gestation, that like less than 37 weeks, do amnioreduction, like aspirate the excessive amniotic fluid. Mild asymptomatic polyhydramnios at term gestation, like more than 37, expectant management is carried on. Then oligohydramnios, it is defined as amniotic fluid index of less than 5 centimeter or a deepest vertical pocket of more than 2 centimeter, less than 2 centimeters. I'm sorry. Causes are early gestation. Oligohydramnios are fetal etiologies like aneuploidy, renal agenesis, posterior urethral valves. Second and third trimester oligohydramnios, uteroplacental insufficiency with fetal growth restriction, or maternal causes such as dehydration or rupture of membranes with normal fetal growth. Preterm, pre-labor rupture of membranes, which is PPROM. We have to do the inpatient management of such patients. Preterm, pre-labor rupture of membranes. Definition is membrane rupture at less than 37 weeks prior to labor onset. Risk factor is prior PPROM, genitourinary infection, for example, ASB and BV. ASB is asymptomatic bacteriuria and BV means bacterial vaginosis. Antepartum bleeding. Infections increase membrane fragility by cytokines. They rupture of cytokines which lead to rupture of membranes. Infections stimulate prostaglandin release. They also cause premature contraction. So with cytokines, there is rupture of membranes, and with prostaglandins, there is premature contractions. Diagnosis: vaginal pooling or fluid from cervix, nitrazine positive blue, nitrogen positive fluid, that is blue fluid, and furning will be seen on microscopy. It is like when we put the amniotic fluid on the slide, so there will be fern-like appearance. Management: if it is less than 34 weeks, do the reassurance, latency, antibiotics, and corticosteroids. If it is less than 34 weeks and I'm sorry, if it is less than 34 weeks, but it is a reassuring condition that, so give latency, antibiotics, and corticosteroids. If it is less than 34 weeks and the situation is non-reassuring, do the delivery. For more than 34 weeks, do the delivery. Complications: preterm labor, intra-amniotic injection, infection, placental abruption, decreased amniotic fluid, uterine decompression, and placental abruption, and umbilical cord prolapse. You can remember as less fluid and is baby hanging out of placenta abruption. What? Remember as less fluid and baby is hanging out of placenta, so this can lead to abruption. Placental abruption can happen because of preterm pre-labor rupture of membranes, PPRM. So this is furning. It can easily be understood by, as you can see, like a fern-like pattern is being made on the slide. It can easily be understood by breaking it down. Preterm less than 37 week gestation, pre-labor closed cervix, that is prior to labor. Okay, and rupture of membranes mean vaginal pooling of nitrogen positive fluid or in posterior fornix. Burning is noticed and increase on Valsalva. Risk factors are those that distend or weaken the membranes, like multiple gestation, prior preterm delivery, history of PPROM, genital tract infections, for example, bacterial vaginosis, antepartum bleeding, and polyhydramnios. Management primarily is inpatient management. If less than 34 weeks, give corticosteroids for fetal lung maturity and give latency antibiotics. If more than 34 weeks of gestation, intra-amniotic infection or deteriorating fetal maternal status, do the delivery and give the group B streptococcal prophylaxis. Here you can see that the placenta is attached to the back of uterus, and in this situation it is posterior placenta, and in anterior placenta the placenta is attached to the front of the uterine wall below the mother's belly. Okay. Then management of PPROM, preterm pre-labor rupture of membranes. Rupture of membranes, which is evident by nitrogen positive, burning on microscopy, that is confirmatory, and amniotic fluid. If it happens less than 34 weeks, so check if it is complicated or uncomplicated. If uncomplicated, do the expectant management, latency antibiotics like ampicillin and azithromycin, corticosteroid and fetal surveillance. If infection, fetal maternal compromise is there, do the delivery. What is that? Intra-amniotic infection, IAI treatment by ampicillin and gentamicin, corticosteroid and magnesium if less than 32 weeks. So if it is between 34 to less than 37 weeks, do the delivery. Give group B streptococcus prophylaxis, for example, penicillin G with or without corticosteroids. So this is a typical furning pattern seen on microscopy when we put the amniotic fluid on slide in the cases of PPROM. Okay, asymptomatic bacteriuria. Definition is more than 100,000 colony forming units per ml bacteria. The risk factors are gestational diabetes mellitus, history of urinary tract infection, and multiparity. Okay, common pathogens are E. coli, most common, then Klebsiella, Enterobacter, and group B streptococcus. First line treatment is cephalexin, amoxicillin clavulanate, nitrofurantoin, and fosfomycin. So can lead to acute pyelonephritis in mother. Asymptomatic bacteriuria can lead to acute pyelonephritis in mother and PPROM or preterm delivery. Okay, so nitrofurantoin, it can cause nitrofurantoin induced pulmonary injury 3 to 9 days after drug with rash, with eosinophilia and lung findings. So the mnemonic for the drugs that we give in the cases of acute asymptomatic bacteriuria is ceiling fan, that is cephalexin, amoxicillin clavulanate, fosfomycin, and nitrofurantoin. And nitrofurantoin, you must remember, is associated with pulmonary injury, with rash, eosinophilia, and lung findings. It can lead to PPROM or preterm labor. Mechanism: intrauterine bacterial enzymatic activity stimulates prostaglandin release, contractions, and then that leads to preterm labor. Increased membrane fragility by degrading the collagen or activating inflammatory cytokines that will lead to premature that will lead to preterm, pre-labor rupture of membranes. Diagnosis: all the women should undergo a screening urine culture at the initial prenatal visit. How do we manage that? We give antibiotics, follow up, repeat urine culture. This is done because a third of patients do not completely eradicate the bacteriuria with initial treatment. If repeat urine culture comes out negative, patients can proceed with routine prenatal care, antibiotics until the end of the pregnancy in any case. Then we have cystitis and asymptomatic bacteriuria during pregnancy. So conditions: asymptomatic bacteriuria. The clinical picture is positive urine culture of more than 100,000 CFU per ml in asymptomatic patients. Screening usually done at 12 to 16 weeks of gestation. Treatment reduces the progesterone to UTI. Treatment reduces the progression to UTI and complications. For example, preterm birth and low birth weight. Acute cystitis: asymptomatic patient with dysuria and urgency with positive urine culture, considered a complicated UTI. How do we manage that? We give nitrofurantoin for 5 to 7 days. Amoxicillin or amoxicillin, are they different? Amoxicillin or amoxicillin clavulinate. Okay, so combined. For 3 to 7 days. Fosfomycin as single dose. No fluoroquinolones in all trimesters. No trimethoprim sulfamethoxazole in first and third trimesters. Okay, so FAN for cystitis and asymptomatic bacteriuria in pregnancy. Amoxi has zero oral. What does that mean? Has an O oral. So amoxi has an O, so we can give it orally, and ampicillin has an I, so we give it IV. Okay. Then pyelonephritis in pregnancy. Treat till the end of pregnancy uh, of you see asymptomatic bacteriuria. What? Pyelonephritis in pregnancy. Treat till the end of pregnancy. Okay. If it's not O and it is U, if you see asymptomatic bacteriuria or pyelonephritis. Pyelonephritis in pregnancy risk factors are asymptomatic bacteriuria, that is more than 100,000 colony forming units, like this. Then diabetes mellitus and age less than 20. Common pathogens are E. coli, most common, then Klebsiella, Enterobacter, and group B Streptococcus. Complications are preterm labor, low birth weight, acute respiratory distress syndrome. Treatment is intravenous antibiotics and supportive therapy. So MMCL, that is macrolide. MCL, what is that? Mycoplasma, chlamydia, and Legionella. What is MCL? Medial cruciate ligament. I'm sorry, it's not that, but I don't know what does it mean? MCL. Okay, so intraamniotic infection or chorioamnionitis. Maternal fever plus fetal tachycardia and increased leukocytes. Purulent amniotic fluid is diagnostic of chorioamnionitis. Common patients with premature rupture of membranes (PROM) occurs before the onset of regular contractions, and in those with prolonged membrane rupture for more than 18 hours, they can develop intraamniotic infection or chorioamnionitis. Okay, these infections are usually polymicrobial. Symptoms are nausea, vomiting, and uterine fundal tenderness. Diagnosis is maternal fever for more than one of the following: fetal tachycardia of more than 160 per minute for at least 10 minutes, maternal leukocytosis, and purulent amniotic fluid. Management is done with the broad spectrum IV antibiotics, ampicillin, gentamicin, clindamycin, and augmentation of labor. So don't confuse the intraamniotic infection or chorioamnionitis with pelvic inflammatory disease, as this also has diffuse uterine tenderness. Pelvic inflammatory disease is uncommon in third trimester because thick cervical mucus won't allow the ascending spread. Pelvic inflammatory disease, non-pregnant and first trimester. Intraamniotic infection or chorioamnionitis, the risk factors are prolonged rupture of membranes for more than 18 hours, preterm premature rupture of membranes, prolonged labor, internal fetal uterine monitoring devices, repetitive vaginal examinations, and presence of genital tract pathogens. So nitrazine positive, Ferning on microscopy, confirmatory amniotic fluid. Diagnosis: maternal fever plus more than one of the following: fetal tachycardia more than 160 per minute, maternal leukocytosis, and purulent amniotic fluid or maternal tachy, that is the latest addition. Management: broad spectrum antibiotics, ampicillin, gentamicin, and clindamycin. Delivery: not C-section, augment labor, and induce. induced labor. Complications of chorioamnionitis can be maternal, postpartum hemorrhage and endometritis, and neonatal complication can be preterm birth, pneumonia, and encephalopathy. Okay, then we have augmentation of the labor is different from induction of labor. Augmentation, active labor already started, but contractions are weak. You want to speed it up. So in augmentation, the contractions are happening. You just want to speed them up, so that's why you augment the labor, right? In the induction of labor, we artificially starting the labor with drugs or mechanical methods. Okay, so they are different. Then we have causes of fetal tachycardia, maternal infection, medication use, for example, terbutaline, poorly controlled maternal hyperthyroidism, for example, beta-adrenergic in the kid, abruption placenta, increased cardiac output demand, for example, hydrops fetalis, indication of anti-D immunoglobulin. If the mother is already sensitized, increased antibody titer, administration of anti-D immunoglobulin is not helpful. Close fetal monitoring for hemolytic disease is done in such a case. Indication of prophylactic administration of anti-D immunoglobulin for Rhd negative patients, that is ROGAM. So at 28 to 32 weeks of gestation, less than 72 hours after delivery of Rhd positive infant, less than 72 hours after spontaneous abortion, ectopic pregnancy, threatened abortion, hydatidiform mole, chorionic villus sampling and amniocentesis, abdominal trauma, second and third trimester bleeding and external cephalic variant, anywhere the blood can mix. Antepartum prophylaxis is not indicated if the father is Rhd negative. Then we have Kelly-Hauer-Betke test. So it is done like this: maternal ghost cells and bright pink fetal cells. Red blood cells from the maternal circulation are fixed to a slide. Slide exposed to acidic pH solution. Maternal hemoglobin A lyses and fetal hemoglobin F remains. Lab technician reports percent of the fetal cells. Anti-D immunoglobulin dosage is calculated using percent of remaining fetal cells. Then we have ABO hemolytic disease. Risk factors: infants with blood type A or B born to a mother with a blood type O. The clinical features are jaundice with 24 hours of birth, anemia, increased reticulocyte count, hyperbilirubinemia, and positive Coombs test. So, jaundice within 24 hours of birth, anemia, reticulocyte count, and hyperbilirubinemia, all of them are indicators of hemolysis. Then we have positive Coombs test. Management: serial bilirubin level, oral hydration and phototherapy for most neonates, exchange transfusion for severe anemia and hyperbilirubinemia. Vaginal hematoma typically presents with hypotension and anemia due to concealed bleeding into the retroperitoneum. Patients also have vaginal pain and vaginal mass. Vaginal hematoma. The risk factors are operative vaginal delivery, infant more than 4,000 grams, 8.8 pounds, that is macrosomia, nulliparity and prolonged second stage of labor. The clinical features are vaginal mass, rectal or vaginal pressure with or without hypovolemic shock. Treatment: non-expanding, so give observation, and if it is expanding, so embolization and surgery can be done. Then we have low back pain. Presentation: pain that radiates down the thighs. Pain worsens with activity and improves with rest. Pregnancy-related causes of acute low back pain should be evaluated and ruled out, for example, preterm labor and pyelonephritis. Low back pain during pregnancy. Etiology: enlarged uterus, exaggerated lordosis, joint and ligament laxity because of increased progesterone and relaxin, weak abdominal muscles, decreased lumbar support. Risk factors are excessive weight gain, chronic back pain in prior pregnancy and multiparity. Imaging is not indicated, and management is behavioral modifications, heating pads, and analgesics. So then we have normal labor. So normal labor progression happens like this. So there is time from admission, and this is dilation of cervix, and station of the fetal head are over here. So like this is centimeter. So you can see that cervical dilation should happen after about 4 hours of admission and 4 centimeter dilation. There must be 1 centimeter dilation, almost 1 centimeter dilation every hour, right? 6, and then we have 8 centimeter dilation over here. So more than 1 centimeter every 2 hour dilation should happen. Okay, so it is more than 1 centimeter dilation every 2 hours. And station is like, this is 0 station at the level of ischial spine. Then it is -1 station, -1. Okay, okay, the dotted line is representing the station, not this one. So here you can see that it starts from above 2 centimeter above the ischial spine, then less than 1 centimeter. Then as the cervix is dilating, the fetus is coming down. When the cervix is 8 centimeter dilated, the fetal head is at 1 centimeter below the ischial spine, so it has engaged, right? So this is how the labor works. Latent 0 to 6, 0 to 6 hours is latent phase. There is no specific time needed for this versus active, where 1 centimeter every 2 hours, good active 6 to 10 hours. Normal contraction occurs every 2 to 3 minutes. How do you check? We use tocodynamometer. Then first stage is 0 to 10 hours, latent phase is 0 to 6, and active phase is 6 to 10. Second stage, delivery of the baby. Second stage, rest is no descent for more than 3 hours in nulliparous and more than 2 hours in multiparous. Third stage is placental delivery, and every 2 hours should have at least 1 centimeter in the first stage, right? So these are the stations. Station 0, when the fetal vertex is at the level of ischial spines. So right now it is not even engaged, it is above that. Then we have active phase rest. Active phase of stage 1, 6 to 10 hours, and also 6 to 10 centimeter dilation. So active phase of labor from 6 centimeter to 10 centimeter cervical dilation at rate of more than 1 centimeter every 2 hours. Active phase arrest is defined as no cervical change in more than 6 hours with inadequate contraction, no cervical change in more than 4 hours with adequate contraction. Late risk factors are late term gestation, fetal macrosomia, and cephalopelvic disproportion. Management is with C-section. Notes: oxytocin is used to augment labor if contractions are inadequate, less than 200 Montevideo units. Okay, it is also used in protracted labor, that is cervical dilation rate of less than 1 centimeter every 2 hours but not arrested labor. Prostaglandin is used for cervical ripening in early labor induction and not in active labor. Disorders of the active phase of labor: protraction, cervical changes slower than expected with or without inadequate contractions, give oxytocin. And if there is arrest, no cervical change for more than 4 hours with adequate contractions, or no cervical change for more than 6 hours with inadequate contraction, give cesarean delivery. Protracted active phase, like this one, mostly the cause of this is inadequate contractions, so inadequate dilation. Give oxytocin, so increase contraction, increase the dilation. Normal contraction occurs every 2 to 3 minutes. It is less than 1 centimeter every 2 hours increase in cervical dilation after it has reached 6 centimeter dilation. Causes are cephalopelvic disproportion, more common in late term pregnancies. Fetal malposition, for example, occiput posterior, occiput anterior is best. Maternal obesity, maternal excessive weight gain, nulliparity, advanced maternal age, and inadequate contractions. Note: epidural length second stage of labor is not the active stage. Not epidural lengthens the second stage of labor, not the active stage of first stage. Okay. So second stage of labor results in birth of the baby, and there can be an arrest, which is like this: 10 centimeter dilation until fetal delivery. Definition: insufficient fetal descent after pushing for more than 3 hours if nulliparous and more than 2 hours if multiparous. Risk factors are maternal obesity, excessive pregnancy weight gain, and diabetes mellitus. Etiology is cephalopelvic disproportion, malposition, inadequate contractions, and maternal exhaustion. Management is operative vaginal delivery and cesarean delivery. Here you can see that the baby's head is too large to pass through the mother's pelvis. That is cephalopelvic disproportion. Physiologic hydronephrosis in pregnancy. Normal change in pregnancy is bilateral kidney involvement, bilateral dilation of renal pelvis, and proximal ureters. Causes of hydronephrosis in first trimester are increased progesterone, which lead to ureteral dilation and decreased peristalsis. Same pathophysiology for increased risk in infections. In second trimester, uterine enlargement, compression of ureters at the pelvic brim. Right hydronephrosis is often more pronounced due to the dextrorotation of uterus. Management: there is no management. Hydronephrosis from ureteral suture. It usually occurs during hysterectomy when ureter is accidentally sutured during ligation of uterine artery or vaginal cuff closure. Risk of ureteral injury is obesity, distorted pelvis architecture from malignancy, and prior pelvic surgery. Presentation. So, as per presentation, initially painless because of post-operative pain medications, and later on there will be non-radiating back pain and costovertebral angle tenderness. On labs, creatinine and urinalysis may be normal. If one ureter is affected, diagnosis is done by the renal ultrasound. Treatment is surgery, for example, suture removal. Differentials are ureteral injury, ascites is seen, and renal vein thrombosis and renal infarction. Hematuria is also seen. Renal interventions, ureteral stents and nephrostomy tubes when etiology of hydronephrosis is ureteral blockage. Polycatheter in disorders of bladder outlet obstruction. Urodynamic studies performed to evaluate mixed urinary incontinence, for example, urgency and stress outside of the pregnancy. What is congenital Zika syndrome? Transmission, it is transmitted by the Aedes mosquito and it is sexually transmitted. Virus destroys neural progenitor cells. Neuronal destruction will lead to thin cerebral cortices, neuronal necrosis, and that will lead to intracranial calcification. Newborn has closed anterior fontanelle and severe microcephaly. Okay, so diagnosis is with reverse transcriptase PCR and neuroimaging. Toxoplasmosis will result in macrocephaly. Macrocephaly. There is ventricular. There is hydrocephalus, so that is definitely going to cause macrocephaly. Hydrocephalus, diffuse intracranial calcification. Cytomegalovirus causes periventricular calcifications. Zika virus causes microcephaly with calcifications and ventriculomegaly, like it is a mix of cytomegalovirus and toxoplasmosis. Pathogenesis of congenital Zika syndrome. Single-stranded RNA flavivirus, transplacental transmission to the fetus, and targets are neural progenitor cells. Clinical features are microcephaly, craniofacial disproportion, neurologic abnormalities, for example, spasticity and seizures, and there will be ocular abnormalities. Diagnosis is with the neuroimaging like calcifications, ventriculomegaly, cortical thinning, and Zika RNA detection. Rubella infection during the pregnancy, it can lead to spontaneous abortion. I'm sorry. Rubella infection during pregnancy can lead to spontaneous abortion, intrauterine fetal demise, more than 20 weeks. It is also called stillbirth. Congenital rubella syndrome. Congenital rubella syndrome can cause deafness, cardiac defects, especially PDA and pulmonic stenosis, hepatosplenomegaly, microcephaly, and cataracts. MMR vaccine is contraindicated during pregnancy, but the patients should be vaccinated during the immediate postpartum period if they haven't been vaccinated before. Central toxoplasmosis, particularly common in Europeans due to their consumptions of undercooked or cured meat, it destroys fetal neural tissue and causes bilateral ventriculomegaly, intracranial calcification, particularly within the basal ganglia. So congenital toxoplasmosis, both of them are the table. Okay, so adults can have a maculopapular rash with toxoplasmosis. Do not get confused with the rash. Non-specific, but it is a finding. Maculopapular rash, myalgias, fevers, and lymphadenopathy. So congenital toxoplasmosis risk factors are undercooked meat, underwashed produce, and unprotected handling of the cat feces. Ultrasound scan will show bilateral ventriculomegaly and diffuse intracranial calcifications. Clinical features are chorioretinitis, hydrocephalus, seizures, intellectual disability, and sensory neural hearing loss. Diagnosis, maternal diagnosis is with serology for toxoplasmosis, immunoglobulin G, and fetal is amniotic fluid PCR. Treatment is with spiramycin. So this is another table for the same thing. I think it's a new table. So they are saying that maternal risk factors are raw undercooked meat, unwashed produce that is contaminated soil, and handling of the cat feces. Clinical features will include a classic triad of chorioretinitis, diffuse intracranial calcifications, and hydrocephalus, microcephaly, that is brain atrophy, or macrocephaly, severe hydrocephalus, seizures, non-specific findings of jaundice, hepatosplenomegaly, rash, and growth restriction. Diagnosis is toxoplasma serology for the PCR. Treatment is pyrimethamine, sulfadiazine, and folinic acid. Okay, so then we have before 18 weeks we give spiramycin. After that, we give pyrimethamine, sulfadiazine, and leucovorin for which is folinic acid basically, because the pyrimethamine sulfadiazine decreases the folic acid level. So to combat that effect, we give folinic acid. Congenital herpes. So mothers have a history of painful genital ulcers. Fetal features are placental and umbilical cord calcification, temporal lobe involvement, meningoencephalitis, sepsis. The long-term sequelae of congenital herpes are blindness, neurocognitive disability, and persistent seizures. Prevention: prophylactic antiviral, that is acyclovir or valacyclovir, beginning at 36 weeks, regardless of symptoms. It reduces asymptomatic viral shedding and outbreak recurrence. Delivery: vaginal delivery if asymptomatic at the time of delivery, and C-section if active lesions are present at the time of delivery. Pregnancy management for the patient with HSV. Prior HSV infection, check for that. If there is no prior HSV infection, give the routine prenatal care. If there is a prior HSV infection, antiviral suppression beginning at 36 weeks, lesional prodromal symptoms during the labor. If they are not present, proceed with the vaginal delivery. If they are present, do the cesarean section. Then congenital cytomegalovirus. Maternal infection can lead to vertical transmission and can spread to the following organs: placenta, liver, and central nervous system. Placenta, if there is cytomegalovirus spreads to the placenta, it can lead to fetal growth restriction and hydrops fetalis. If it involves the liver, it can lead to hepatosplenomegaly and intrahepatic calcifications. If it involves CNS, it will result in microcephaly, ventriculomegaly, and bilateral periventricular intracranial calcifications. Diagnosis: maternal infection. To rule out that, go look for serology. Fetal infection, do amniocentesis. Management: maternal antiviral therapy has not been proven effective. Hence, management is generally expectant. Abortion in cases where fetuses have severe congenital cytomegalovirus infection. Congenital cytomegalovirus, ultrasound findings will show periventricular calcifications, ventriculomegaly, microcephaly, intrahepatic calcifications, fetal growth restriction, and hydrops fetalis. Neonatal features are petechiae, which can be blueberry muffin rash, hepatosplenomegaly, chorioretinitis, and microcephaly. And long-term sequelae include sensory neural hearing loss, seizures, and developmental delay. Then we have these things over here. That is congenital Zika virus infection. I think we have talked about that before. So it is a single-stranded RNA flavivirus, transplacental transmission to the fetus, and targets the neural progenitor cells. The clinical features are microcephaly, craniofacial disproportion, neurological abnormalities, for example, spasticity, seizures, and ocular abnormalities. The diagnosis is neuroimaging, calcifications, ventriculomegaly, cortical thinning, and Zika virus RNA detection. So congenital toxoplasmosis. So all three of them are listed over here. We have talked about this before, but let's see it for the last time. Maternal risk factors are raw or undercooked meat, unwashed produce, that is contaminated soil, handling of the cat feces. The clinical features include a classic triad of chorioretinitis, diffuse intracranial calcifications, hydrocephalus, microcephaly, which is brain atrophy or macrocephaly, severe hydrocephalus, seizures, non-specific findings like jaundice, hepatosplenomegaly, rash, and growth restriction. So congenital listeria. There is a thing over this corner that is about listeriosis. So they are saying that listeriosis in neonates, elderly and immunocompromised, granulomatosis infantiseptica transmitted to the fetus transplacentally, early septicemic form 1 to 5 days postpartum, delayed meningitis form 10 to 20 days following birth. Then intracellular pathogen, listeria is an intracellular pathogen. Okay, cell-mediated and humoral immunity develops against that, and once cell-mediated immunity, only cell-mediated immunity is protective because antibodies cannot enter the cells to kill the pathogen. Then we have congenital listeria. Listeria infection occurs after consuming of unpasteurized dairy products, deli meats, frozen. Fetal infection leads to following: spontaneous abortion, preterm delivery, multiple abscesses, granulomatous infantiseptica. Ultrasound findings will show dilated loops of bowel and ascites. Fetal mortality is high, that is intrauterine fetal death. Causes of granulomatosis and pantiseptica is systemic infection, disseminated abscess, respiratory distress, skin lesions. Signs of meningitis already developed. So these are the causes of granulomatosis and pantiseptica. Okay. There is another diagram. So they're saying that when we use a contaminated food like deli meats or frozen something, so febrile gastroenteritis, there will be translocation of the bacteria into liver, spleen, and what is that? I don't know. Liver and spleen. So subclinical focal pyogranulomatous hepatosplenitis that will elicit an immune response. The immune response will stop its transmission to the bloodstream. But if it enters there and if there is no immune response, so it will go to the bloodstream and will cause meningoencephalitis. Especially it affects the elderly and the immunocompromised people. In the bloodstream, it will cause bacteremia, and in placenta, it will cause placentitis, abortion, stillbirth, neonatal sepsis or meningitis, and from here it can result in a retroinfection and again affect the liver and spleen. Okay, then we have sequelae of the congenital infection. Common sequelae of the congenital infection are cytomegalovirus causes sensory neural hearing loss, toxoplasmosis will cause chorioretinitis and obstructive hydrocephalus. Syphilis will cause osteoarticular destruction like Hutchinson's teeth and saddle nose. Rubella will cause cataracts and sensory neural hearing loss. Cerebral venous thrombosis can be seen in after pregnancy due to hypercoagulable state. Do MR venography, not cerebral angiography, which is invasive. Then cerebral venous thrombosis, the risk factors. Inherited thrombophilia, for example, protein CS deficiency, factor V Leiden, and antithrombin deficiency, pregnancy and postpartum, oral contraceptives, malignancy and infection. The clinical features are headache, elevated intracranial pressure, for example, vomiting and papilledema, seizures and encephalopathy. Diagnosis is MRI of the brain with venography, and treatment is anticoagulation, heparin acutely. What are the vaccines that we should offer during the pregnancy? Recommended vaccines are Tdap, that is for the tetanus and diphtheria and acellular pertussis from 27 to 36 weeks, inactivated influenza, and Rho-D immunoglobulin. Teenage boosters so reduced diphtheria component. Tdap is early, so normal component, original one. Teenage boosters so reduced. Tdap is teenage booster, reduced diphtheria component. Okay, so it has a reduced diphtheria component. D-type is early, so normal component. So D-type has increased diphtheria toxin, and Tdap, which is a teenage booster dose and also given in pregnancy, has a decreased diphtheria component because diphtheria affects the children mostly, maybe. Indicated for high-risk pregnancies: hepatitis B, hepatitis A, pneumococcus, haemophilus influenza, meningococcus, and varicella zoster immunoglobulin. Contraindicated are human papillomavirus. These vaccines are not you're not supposed to administer these vaccines. HPV, MMR, live attenuated influenza, and varicella. All pregnant women without any contraindication, that is prior allergic response to vaccine, should receive inactivated influenza vaccination as soon as it becomes available. This is because pregnancy is associated with high risk of influenza-associated morbidity and mortality. Inactivated vaccine is safe during every trimester and while breastfeeding. Activated vaccine is safe only during breastfeeding. Then we have syphilis in pregnancy. So for syphilis, everyone gets a screen in the first prenatal visit. Patients are tested with two categories, non-treponemal and treponemal serology. Either may be used for screening, but positive results require confirmation with a test from the alternate category as false positives are common. Treatment is benzathine penicillin G IM, one dose weekly for 3 weeks. Patients who are allergic to penicillin need to be desensitized because alternate medications are either ineffective, contraindicated, or have limited data in pregnancy. Syphilis in pregnancy screening is universal at first prenatal visit and third trimester and delivery of high risk. Serologic test, non-treponemal RPR and VDRL. Treponemal is FDA ABS. Treatment, intramuscular penicillin G, benzathine for 3 weeks. Pregnancy effects are intrauterine fetal demise and preterm labor. Fetal effects include hepatic, that is hepatomegaly and jaundice, hemolytic anemia, and decreased platelets, musculoskeletal long bone abnormalities, and they can be failure to thrive. So then we have granulomatosis and pantiseptica, which is a complication of Listeria monocytogenes. So positive organism is Listeria. Pregnant women due to relative immunosuppression are at increased risk of invasive disease, that is bacteremia, and fetal infection via transplacental transmission. Granulomatosis and pantiseptica is caused by acquiring infection in early pregnancy, for example, first and second trimester. This can lead to intrauterine fetal health more than 20 weeks, because if it is less than 20 weeks, it is miscarriage. Okay. Infection in the third trimester does not lead to fetal demise but can lead to fetal distress, preterm delivery, or early onset neonatal sepsis. The fetal distress associated with respiratory distress, not receiving oxygen. Prevention: avoid foods contaminated with listeria, for example, raw meats and vegetables, unpasteurized dairy products, and processed, for example, dairy meats. Proper hand washing after handling soil or decaying vegetation. Listeria monocytogenes, pathogenesis, foodborne transmission, bacterial invasion of initial intestinal epithelial cells, transplacental passage to the fetus. The clinical features include febrile gastroenteritis in immunocompromised host, invasive disease, for example, sepsis, meningitis in neonates and pregnant women, elderly and immunocompromised. Lab findings include gram-positive fluorescence culture, for example, stool, blood, and CSF. And treatment is supportive care of gastroenteritis in normal host and parenteral antibiotics for the invasive disease. Then we have pubic symphysis diastasis. It means that the joint between the two pubic bones, like suppose there's a pubic bone, okay, it does not look like it, but the symphysis looks something like this. So the joint which is between them, it breaks down or it just opens up. So this is called as pubic symphysis diastasis or dehiscence of the joint. Okay, so it is the symptomatic widening of the pubic symphysis. During pregnancy, increased progesterone and relaxin will lead to physiologic widening of the pubic symphysis. Symptomatic diastasis can occur after traumatic delivery. The pain is exacerbated by walking, weight bearing, or position changes. Management is conservative with supportive care. Most patients recover within first 4 weeks postpartum. Differentials: femoral nerve damage can occur as a result of Mac-Robertson maneuver, numbness over the anterior and medial thigh, inability to extend the leg or flex the hip. There will be diminished patellar reflexes, pubic symphysis diastasis. Risk factors are fetal macrosomia, multiparity, precipitous labor, and operative vaginal delivery. Presentation or difficulty ambulating, radiating suprapubic pain, pubic symphysis tenderness, and intact neurological examination. Management is conservative, NSAIDs, physical therapy, and pelvic support. Then we have Mac-Robertson maneuver. What is Mac-Robertson maneuver? In this, legs are flexed onto abdomen, causes rotation of pelvis, alignment of sacrum, and opening of the birth canal. Then we apply suprapubic pressure applied to the fetal anterior shoulder. So this is basically done when the shoulders are not being delivered, I guess. So this is Mac-Robertson maneuver. External cephalic variant. The latest table is like this. Procedure is manual rotation of fetus to cephalic presentation, decreases cesarean delivery rate. Like it is done in the breech pregnancies, like in which the fetus, buttocks are on the pelvic outlet, not yet, towards the cervix, and head is on the opposite pole, or maybe any other kind of breech, but manual rotation of to cephalic presentation decreases cesarean delivery rate. Indications are breech, transverse presentation, that is buttocks and feet, more than 37 weeks of gestation. Absolute contraindications to vaginal delivery are prior classical cesarean delivery, prior extensive uterine myomectomy, and placenta previa. Complications include abruptio placenta and intrauterine fetal demise. So here you can see that it is done if more than 37 weeks with breech to decrease the risk of premature delivery, and also baby keeps turning until 37 weeks. So we do extend cephalic variant after 37 weeks, because even if the baby is breech at 32nd or 33rd week, there are the chances that the baby will rotate into the cephalic position by the 37th week or more. Okay, so if it has not happened until 37 week, then we do it. And how do we do it? External cephalic version, we do the forward roll like this. Breech presentation. Breech types are as follows. There is a frank breech in which hips are flexed and knees are extended. Like the child looks something like this. This is the head and this is the body, and then legs are facing upwards. So these are the buttocks. So the hips are flexed, but the knees are extended. This is frank breech. Then complete breech is hips and knees are flexed. So it is something like this. The baby is over here and the legs are like this. Like this. Okay, that's a very bad diagram. And incomplete is one or both hips not flexed, feet presenting. So that is the footling breech or incomplete breech. Risk factors are advanced maternal age more than 35, multiparity, uterine diadelphys, septate uterus, uterine leiomyomas, fetal anomalies, for example, anencephaly, preterm that is less than 37 weeks of gestation, oligohydramnios and polyhydramnios, and placenta previa. Management is external cephalic version and cesarean delivery. Risk factors include multiparity, multiple gestation, uterine anomalies, for example, septate uterus, fetal anomalies like hydrocephalus, leiomyomas, limit fetal mobility, prevent fetal cephalic engagement, and placenta previa. Physical examination has subcostal pain, palpation of a hard mass near the uterine fundus due to the fetal head, and lack of fetal presenting part on the digital cervical examination. Management. Other contraindications to vaginal delivery present C-section. No contraindication to vaginal delivery extends cephalic version, and it is done at 37 weeks of gestation. So these are the breech presentation types. This one is frank breech, in which hips are flexed but knees are extended. This is incomplete breech, in which one knee is flexed while the other is extended. The complete breech is in which both the knees are flexed and hips are also flexed. Single footling is when in which the foot is presenting, and double footling is in which the both the feet are presenting. Okay. Then we can do internal podalic version only for helping the vaginal delivery of a second twin. Indicated delivery of a second twin. Procedure: grasp the feet by inserting hand in the uterus and perform the breech extraction like this. So place the hand in the uterus, grab the fetal foot, and deliver the baby feet first. Then we have gestational diabetes. I think we should go with the gestational diabetes in the next session. It was a long session, and next session will also be a long session. So until next time, Allah Hafiz, Manila, and take care.